Yeah. So today I will be talking about something which comes in the TMJ surgeries, and a lot of us do face some problems, uh, intraoperative complications, and maybe a little bit after the surgery, some postoperative complications can come up. So the topic for today discussion is avoiding complications and TMJ surgeries. I have no conflict of interest. So let me put in the first poll questions to the participants. Can you just project the poll question? What, in your practice or opinion, is a common complication in the open joint TMJ surgery? And you can vote in here, and we will see the percentage of voting, and that will set the tone for the further presentation. Yeah, so we have the answers, and 42% think that the nerve damage is the most common complication which happens, followed by malocclusion and hemorrhage. Yeah, that's good, so that we know that that we are probably on the right track here, and definitely nerve damage and hemorrhage are the most common complications which occur during the open joint TMJ surgery. So the objectives for today's discussions are that we would know what are the potential complications in the TMJ surgery and what are the strategies to avoid them. It is a neural damage or a vascular damage or injury to the adjacent anatomical structures. Which procedures of TMJ have potential complications? As we know that arthroscopy is relatively safe, would not be discussing much about the arthroscopy here, but mostly about the open joint surgery and total TMJ reconstruction. And we would also know what are the best practices to avoid the complications. Why there is so much hullabaloo about TM joints? Because TM joint is surrounded by the neurological structures of cranial nerves of fifth and the seventh, trigeminal nerve and the facial nerve. And there is important vasculature which surrounds the joint in terms of maxillary artery, superficial temporal artery, inferior alveolar neurovascular bundle, and the mesenteric artery. Moreover, TMJ is also intimately involved with the middle cranial fossa, and the close proximity of ear potentiates the damage to the external auditory canal, the tympanic membrane, and the middle ear. Although carotid is inferior, but it is adjacent to the joint. So the surgery can affect any one of these things. If we categorize the complications, we categorize them as anatomical and neural. That is the middle cranial fossa, which the glenoid fossa shares its roof with, the middle ear, tympanic cavity, parotid gland, fifth and the seventh cranial nerves. The vascular complication category would be for maxillary artery damage, pterygoid plexus of veins which are there, and inferior alveolar artery. Infections of the TM joints are rare, but periprosthetic joint infections after TJR is definitely a problem. And then we have biomechanical and biochemical, that is effect on occlusion, and metallosis, which is not seen these days, but earlier with the total joint replacements, which was metal and metal, we would see a lot of metallosis and a lot of problems with those kind of joints. But now we have plastic on metal, so that has reduced a bit. If you look at the neural complications, every approach, may it be endural approach, may it be modified preauricular approach, or may it be submandibular approach, the facial nerve is there. And every approach to the TM joint involves the area which corresponds to the division of the facial nerve, either the superior or the inferior. And then we know that the facial nerve crosses the zygomatic arch at a distance of 8 millimeters to about 3.5 centimeters. But then we did is it for all the races? We did our study on the cadavers, and we saw that most of the branches of the facial nerve do cross at the same area which has been described, but the bifurcation of the upper branch, where it bifurcates into the cervical and the upper branches, we see that in the Indian population, it is slightly less than what is reported in the literature.